Uh, Nakul, we are alive.
Yes, sir, you can.
A warm welcome and good evening to all participants out here and experts out here. This is our ISAR UNS Fertility Catalyst webinar. We are blessed with Dr. Amit Patki sir and Dr. Asha Bakshi ma'am giving UNS an opportunity, Universal Nutriscience, an opportunity to collaborate with ISAR and organize this monthly webinar, which is happening for the past 16 months. In fact, this is the 16th in the series. And this reminds, I think this would remind most of us about this beautiful song, which was in this beautiful movie, which had come out in some part of our life. I'm Dr. Manish. I'm the Medical and Regulatory Affairs Head at Universal NutriScience. Literally blessed to have Dr. Nandita ma'am as a chief guest, as well as Dr. Madhuri Patil ma'am as guest of honors. And with support of Anu Agarwal and Dr. Fessy Lewis, our SR UNS Fertility Catalyst webinar has reached the milestone of 16, and I'm sure we'll achieve many more milestones. Along with me, two of my dynamic duo and the foundational pillars of Universal NutriScience, Yogendra and Manoj are also here. And I'll request Yogendra to give a welcome note before we proceed further. Yogendra, over to you.
Sure, doctor. Thank you so much, doctor. And thanks you for the warm welcome for everyone. And very good evening to everyone. A very warm welcome to each one of you as we begin the 16th series of ISAR Fertility Catalyst webinar. And it is truly an honor to see so many esteemed IVF gynecology expert across the India joining us today. Doctor, actually, you are the true catalyst. You who is, consistently driving progress, inspiring innovation, and transforming life nationwide through your dedicated effort and reproductive health. So at UNS, we take immense pride in being the one of the India's fastest growing nutraceutical company, and our commitment is simply yet powerful to improve the lives through high quality evidence based product. Our infertility portfolio featuring CoQ 300, CoQ LC, CoQ Fort, CoQ Fem, and CoQ Man is crafted to empower couples on their journey towards a parenthood. With that, it is my privilege to invite our medical head, Dr. Manish Garg and Sanskruti, to introduce today's distinguished speakers and set the tone for to this impactful session. Thank you, Doctor, once again, and over to you, Doctor.
Thanks a lot, Yogendra. So what I'll do is I'll just briefly introduce Dr. Anu Agarwal ma'am and Dr. Fessy Lewis sir, who are the real sutradhars for this webinars, with whose support we have been driving this webinars. Madam is from the holy city of Varanasi. She is the director of Vansh Fertility and Test Tube Baby Center. She is the current executive committee member at ISA, librarian, joint secretary, very active on the research and publication front. Dr. Fessy Lewis, sir, professor and HOD at Amrita Institute of Medical Sciences, has held several positions of esteem repute at different societies, and also is active on the research and publication front and has several awards to his credit. And with this, I'll request Anu ma'am for taking over the proceeding, ma'am. Over to you, Anu ma'am and Fessy Lewis, sir.
Thank you. Thank you, Dr. Manish. Good evening to all the esteemed doctors present here. And along with my co-convener, Dr. Fessy, it's a pleasure to welcome you all in this 16th episode of ISAR Fertility Catalyst series. In previous episodes, we covered many topics like PCOS, endometriosis, hysteroscopy. And so, first of all, I would like to acknowledge Central Team ISAR for giving us this wonderful platform to share our knowledge. And today, Dr. Asha Bakshi ma'am is here with us. So I request our dynamic secretary, ISAR, Asha Bakshi ma'am, to give her pearls of wisdom to us. Asha Bakshi ma'am.
Thank you very much, Anu, for conducting such good webinars. ISAR, under the leadership of Dr. Amit Patki, is really doing very good work, and we all have witnessed in last 2 years great amount of work and lots of power-packed webinars, master classes, international collaborations. So it's really, I'm very fortunate to be working in this team and to have such good coordinators like Dr. Fessy Lewis and Dr. Anu Agarwal, who are very good clinicians, at the same time great academicians also. And the topics every time they have selected are such topics that they are useful to every fertility specialist. And ovulation induction, we all know, is such a thing. Sometimes you get too many eggs, sometimes you get too less eggs, sometimes you are very happy that you got good number of eggs, but then your embryologist puts you off. Oh, eggs are not good, and you really feel very upset. So today we are going to learn a lot about ovulation induction from the great speakers, Dr. Sujata Kar, who is a master, and Dr. Rajesh Kodia. And today we are very, very fortunate. And on behalf of ISAR, I would really like to welcome our own Dr. Nandita Palshetikar, who is a lady with vision, very intelligent, beautiful, and very forward looking. She's updated with the latest topics, and every time you meet her, and she comes up with something new in the form of rejuvenation. So I welcome you, Dr. Nandita, and you are a good friend as well as a very good guide. And then we have Dr. Madhuri Patil, who is what I call is Chalta Firta Encyclopedia of ISAR, of infertility. Any topic, any problem you have in Madhuri, iska kya karna chahiye, ye hormones mein kya hona chahiye, and she has got an answer. And whatever you say, ki this I would like to do. No, the latest evidence says that this should not be done. So she is very updated with everything. Then I would also like to welcome today the chairpersons are from all over. So from North, I have my good friend Dr. Neelam Ohri, who we all know has organized lots of conferences and is a very knowledgeable person. Then Dr. Rajshri Goyalkar, she's from Kota, and I call her Nightingale of ISAR. She sings so well, and she's also a very good clinician. And Anu from South, we all know for her wonderful work, her wonderful contribution to ISAR, a very active person and a very glamorous person also. And then I'm very fortunate that today we have so many people from Madhya Pradesh, Monica Singh, Randir Singh, and Shweta Kolja. We all know we can call Randir and Shweta as the masters of webinar. They've really done very good work with the webinars, and they are doing lots of contribution for ISAR, and we are thankful to you, Monica and Randir. And Shweta, she is again a very active person, very technically very updated, and especially I would like to congratulate her because she has not only done fellowship in infertility, but recently she has done MSc in embryology. So with such good faculty and such good faculty and members of ISAR, today we are going to have a very good interactive webinar, and I look forward to learning more from all the doyens of the infertility. So thank you very much again, Anu and Fesi, for giving this opportunity, and let's have a very good interactive webinar. Thank you.
Thank you, Dr. Asha Bakshi, so for this words of wisdom. With this, I need to introduce our one and only Nandita Madam.
Thank you, Dr. Fesi. It's an honor to invite our today's chief guest, beautiful and dynamic Dr. Nandita. Ma'am is eminent IVF specialist with over 30 years of experience, and she's medical director of Bloom IVF, over 10 centers all over India. She's pioneer in India, latest technique like ICSI, laser hatching, blastocyst culture, spindle view, oocyte, embryo and ovarian tissue freezing, IMSI, in vivo vaginal culture. She has delivered 103 orations and more than 1,000 lectures, authored more than 100 chapters and papers, and edited 25 books. She's past president of FOXI, ISAR, IAGE, MOGS, MOGS, and MSR. She's FOXI representative to FIGO member, FIGO project head, and she's co-chair REI committee, AOFOG. Welcome, Nandita ma'am.
Unmute yourself.
Yes, yes.
Good evening, everybody. I think I don't want to take everybody's names. Asha has already touched upon it. And I think that was a beautiful way of introducing everybody. But it's good to see all the friends and everyone. You know, ISAR is an organization which is an amazing organization, one of the oldest organization in the fertility space. And it has grown by leaps and bounds. I think I still remember when the founder members got together and formed ISAR. And it has come a long way from just 20 members to today. I think it's about 5,000 plus membership. I'm sure Asha will tell us the right number. But it is an organization which allows. I think which helps you grow, helps you learn, and very good academics. And whenever I'm attending any SR webinar or lecture, I think I always come back with some knowledge that I gain out of these, because the speakers are very well read. And today we have ovarian stimulation. I think that's a fantastic topic. I mean, there's always something new, and especially PPOS. I think it's the new kid on the block, and it'll help a lot of patients. With their reducing their cost and everything. And I think it's better that we learn more about it, because its applications have really expanded from poor responders to endometriosis to cancer patients and even PCOS patients. So I think it's an excellent way, and there are different ways of doing it. You can start the PPO stimulation in the luteal phase, and then go on to the uh, follicular phase and actually do an embryo transfer. So by doing embryo pooling, so there are new things, new concepts which have come, and I think it'll be wonderful. As always, I would like to really congratulate Amit and Asha. I think Asha has been the pillar who has been, I've come from many webinars and I've seen Asha everywhere over there. So I think a perfect the secretary work she's done, and really given a lot of support. And of course, I cannot end without saying Sujata is also here. We worked together during my year, and we were a great team. And Madhuri is another person whom you can always depend on. And I think that is the beauty of Madhuri, that she's very loyal to her friends and always ready to help. So Madhuri, thank you for being there for all of us. And of course, everybody else, but I'm not going to say Anu and Fessy, congratulations. Thank you for inviting me. And the 16th webinar, it's really great. And UNS has really been good with supporting this endeavor. So thank you very much for inviting me here. And this is a wonderful topic, very close to my heart. So I will try to be there as much as I can. So I wish you all the best, and thank you very much for inviting me.
Thank you, madam. Thank you, Nandita madam, for coming here and all motivating all of us and guiding us all throughout many years. Thank you, madam. Yeah, I think next Dr. Anu will be introducing our Madhuri madam.
Yeah. So it's a privilege to invite our guest of honor, Dr. Madhuri Patil ma'am, who is really, she's encyclopedia of knowledge. Ma'am is clinical director of Dr. Patil's Fertility and Endoscopy Clinic, Bangalore. She's associate editor, Fertility and Sterility, and official publication of ASRM. She's chairperson Aspire, SIG, Reproductive Endocrinology, vice president and founder member of PCOS Society India, and vice president of SR. She's founder member and president of Fertility Preservation Society of India, board member of AE PCOS Society, and member Education and Accreditation Committee, Aspire. She's associate editor of the Onco Fertility Journal. She has many awards. She has received many awards. Dr. Duru Shah Lifetime Achievement Award from ISAR, Vidya Vibhushan Award from ICOG 21, and she is founder chairperson of Karnataka chapter of Indian Society for Assisted Reproduction. So welcome, Madhuri ma'am.
Thank you for inviting me here today. Good evening, everybody. So I think Dr. Amit and Asha have done a good job in their 2 years, and there are many learning. I mean, we've had lots of webinars as well as master classes, and I think masterclass is one of the best way where we discuss one particular topic, and therefore all the people have good take-home messages. And the topic chosen today is ovulation induction, I think, and that is very important because now we have a lot of changing protocols which are there. And I'm sure all the delegates who would attend this webinar would benefit. We have two very good speakers, Dr. Sujata and Dr. Rajesh Koradia. And Sujata will discuss all the different newer protocols which are there and what is the advantage and disadvantage, whereas Rajesh Koradia will discuss on the progesterone primed ovarian stimulation, which is in thing now, especially in oocyte donors and also in a freeze-all cycle. But we should also remember that when we talk about ovulation induction, that is the main crux of having the best success with ART. So your oocyte and embryo quality is basically going to depend on what you give the embryologist. And I think selecting the best protocol is most important. And I would like to also appreciate Dr. Fesi and Anu Agarwal for conducting these webinars. And this is the 16th one which we are doing. And also the UNS for supporting this webinar. And I'm sure this webinar would be a great success with a lot of take-home messages. Thank you. I'll just
Thank you, Madhuri ma'am. Thank you, ma'am.
I'll just join again in 10 minutes, okay?
Okay, thank you, madam. Thank you, madam, for coming and joining. I think without wasting time, we'll go to the scientific session. We have the first session in which first we will invite the chairpersons. We have first chairperson Dr. Neelam Mohuri. Madam, can you show the slide of Neelam, madam? Madam is the medical director of New Life Hospital and Advanced Fertility and Gynec and Laparoscopy Center, Varanasi. Chairperson of ISAR UP chapter and secretary of UP IAG, vice president of Varanasi Menopausal Society, past president of Varanasi ONG Society, organized several conferences and recipient of Shani Kasi and Kasi Ratna awards in various publications, national journals, and various chapters written and for books. Well, we welcome Neelam madam. Our next chairperson is Dr. Monica Singh. She is the consultant reproductive medicine at Bhopal Fertility Endoscopy Center and Professor London Medical College and Bhopal, managing committee member of ISAR, vice president of Bhopal ONG and Menopause Society, honorable secretary of MP chapter of ISAR.
Thank you, sir. Thank you, sir.
And I think she all knows her because she is one of organizing secretary of ISAR 27th conference in 2023. Our next, we welcome you, Dr. Monica. And next chairperson is Dr. Rajashree. I cannot pronounce that name. Sorry for that. Deepak Godkar. She is the Foxy Training Center for Endoscopy and Infertility, recognized by NARCHI also. And the director of Rajdeep Fertility Hospital and Rajdeep IVF Center, Kota, Rajasthan. And she was the organizing chairperson of Rajyakon 2017 State Conference of Rajasthan and several prestigious conferences.
Thank you, sir. Thank you very much.
You welcome you. Sorry for that. I could not.
No, it's okay. It's okay, sir. No
so
problem.
our two chairpersons to introduce our speaker, Dr. Sujata Kar. Can you show that?
Can I have a CV?
Dr. Sujata's CV.
Neelam, I think you should just finish off with one or two sentences.
It's really a great pleasure to introduce a person of great eminence and my dear friend, Dr. Sujata. She's a practicing gynecologist, endoscopist, and expert in assisted reproductive techniques for the last 28 years. Her area of interest is polycystic ovarian syndrome, proteomics, and male infertility, and scope of stem cells in gynecology. She has so many major achievements like best graduate and 7 gold medals in MBBS MD, credited with the first IVF baby of Eastern Orissa, first TESA frozen embryo and laser hatched babies of Orissa, and she has many awards to her credits, and she has many publications and research papers, and she has held many positions, important positions like Vice President ISAR India, Executive Committee member of PCOS Society, FPS of India, and Chairperson of Odisha chapter of ISAR. So we know her very well, but for the sake of this introduction is there. So we are really eager to listen to her about the novel methods of ovulation induction. So over to you, Sujata.
Welcome,
Thank you,
Sujata
Neelam.
ma'am. Always looking forward to your talk, Sujata ma'am.
Thank you so much. I hope I'm visible now, right? I'm there. My
Yes.
slides are visible?
Yes,
Yes,
ma'am.
yes, yes.
Okay. So thank you very much, everybody, for giving me this opportunity and this lovely introduction. Let me start my topic without wasting too much time. I'm going to speak about novel stimulation protocols. And as discussed, I will not be talking about PPOS because Dr. Rajesh is going to speak about that. So the fact remains that despite a lot of advancement and improvement in technology in ART over the last 40 years plus, we have come a long way, but still the fact is that with IVF ART still remains inefficient, with overall live birth rate per oocyte retrieved reported to be as low as 5 to 10% per oocyte retrieved. And as of now, maximum about 60% of couples visiting an infertility center achieve their desired goals. And still the cost, the time of a live birth, the risk of multiple pregnancy, the risk of OHSS, etc., and potentially some birth defects related to IVF are still plaguing our success. So today in my lecture, I'll start with some basic concepts of ovarian stimulation and then go on to talk about how to optimize ovarian stimulation or ovarian response by manipulating each phase of the stimulation cycle, meaning the luteal-follicular transition, the early follicular phase, the preluteal phase, the luteal and random start stimulation, and a little bit about how to optimize the trigger. So the novel ovarian stimulation approaches that we talk of today is based on the fact that together with advanced cryopreservation and availability of the antagonist, that allows for a total disarticulation between the timing of menstrual cycle, ovarian stimulation start, and embryo transfer. And today we have probably more than 20 different GnRH antagonist protocols which have been reported. And the process goes on through the process of refinement and improvement. The point is how to optimize ovarian stimulation for each patient, how to individualize it, and how to maximize the oocyte numbers that we need. But of course, we need to understand some basic concepts which many have remained the same over the years, but there are many new concepts that have led to these novel, the appearance of these novel stimulation protocol. All of us know about the concept of FOT and FOI, the concept of the difference between ovarian reserve versus ovarian sensitivity. Now, ovarian responsiveness, as we understand, is assessed by ovarian markers such as AFC, AMH, along with age, BMI. The aim is to predict poor, normal, or hyper responder. However, patients always are there with unexpected poor response. Poseidon group 1 and 2 who have normal ovarian responsive markers or ovarian markers, yet they respond poorly. And so this gives to the rise of two concepts. One is follicle output rate, the FOT, which is a model to assess unexpected hyperresponsiveness. It is calculated as the ratio of the number of pre-ovulatory follicles obtained in response to ovarian stimulation when you compare to the antral follicle count on day 2, the small antral follicle count. So what was the number of antral follicle counts on day 2 and how many follicles do you have as a result of ovarian stimulation? That, when compared to follicle oocyte index, FOI, is the ratio between the total number of oocytes collected versus the number of small follicles that we had in the beginning of the stimulation cycle. And as we know, the FOT and FOI is calculated in this manner. The pre-ovulatory follicle count on day of HCG divided by antral follicle count. FOI is the number of oocytes actually retrieved at OPU, which is divided by AFC. Obvious reasons, if FOI is a better indicator and it is more practical indicator, gives us more information. Now, if you look at this picture, this is a case of normal follicle output ratio. Anything more than 50% 50% of what you have seen or what you expect in the day 2 AFC, and what you get is considered as a normal FOI, and low when you get less than 50% of follicles that you see. Again, follicle output ratio, the similar thing it shows. Here you have very good ovarian reserve, but you get the response has been poor, so you get less than 30% of what you expect or around that. And poor ovarian reserve, from the beginning you have very low ovarian reserve. You were expecting about a 5 or 6, but the ovarian response has been very good. The stimulation protocol has been very good, because you were expecting 5, 6 and you got about 3 to 4 oocytes. So this is one concept we need to understand. The second is the fact that there is now a concept of multiple follicular waves in one menstrual cycle. Earlier, we had thought that there are recruitable follicles appear only in the pre-follicular phase, or the recruitable follicles are there in the early follicular phase of a menstrual cycle. But now we know that possibly there are 2 or 3 waves of follicular growth that happens normally, but is suppressed in a menstrual cycle, and that can be harvested, or we can aim to even take advantage of those follicular waves that can be retrieved during each menstrual cycle. In fact, some women who have a longer menstrual cycles, you can also have 3 waves, is what the new concept tells us. The follicular wave that emerges in the early or mid follicular phase is ovulatory, as we know in an ovulatory cycle, while the waves that come in the luteal phase, or again in the late luteal phase, or in the mid cycle phase, those usually are anovulatory, and recruitable window is longer in the luteal phase. So the fact, I'm just giving you one example. All cycles are different. Oocyte cohorts can be different, and embryos from different cohorts also can be different. Take the example of this lady. She's 35. Her BMI was 43. She's been married for 4 years, and she's going the first cycle of IVF with me. Her AMH is 1 nanogram, and her antral follicle count is 4 plus 3. So 7 to 8 follicles is what I am expecting when I see her. So in the first cycle, I give her 300 IU, recombinant FSH, combination of recombinant and an HMG purified. Fresh ET is done on day 3, 2 embryos, and 2 are FET. 2 are frozen, and that was also transferred, and she did not get pregnant. So basically 4 embryos were formed day 3, and she underwent 1 fresh cycle and 1 frozen cycle, and she was not pregnant. So this is her embryology note. But in the second cycle, how I have changed is that in the second cycle, I started her with a higher dose, 375. I gave her a dual trigger and considered and did all freeze. And you would not believe that we got 10 blastocysts, which were frozen in 5 straws for this patient. So how you change the stimulation on the starting dose of the FSH, and so many other factors, and the fact that 2 different oocyte cohorts can be very different, not only from the point of view of number of oocytes retrieved, but also from the point of view of the number of aneuploidies that are present in the oocyte. Even in the embryo, the aneuploidy rate, etc., can be very different in different cohorts. So understanding ovulation induction is really difficult. So now let us look at how we can optimize ovarian response by looking at optimizing each phase of the ovarian of the menstrual cycle, and how we can optimize. The first is optimizing luteofollicular transition phase. Now this is the area you can see here. One sec. This is the area, which means towards the end of a menstrual cycle, when there is luteofollicular transition. As the GnRH antagonist protocols, like we use very commonly, lacks the process of pituitary downregulation. Like normally in an agonist cycle, we would have started downregulation from day 21. That does not exist in an antagonist cycle. And so there is an endogenous FSH is not suppressed, and there's a transient increase in endogenous FSH towards the end of the cycle, and that starts recruiting the follicles for the next menstrual cycle. So this is an area which we can target about 4 to 5 days before the actual menses, that you can target to optimize. What are the various ways? You can start by you can think about giving estradiol valerate, antagonist premenstrual, or androgen. So estradiol valerate about 6 to 10 days before a menstrual cycle. This is one of the commonest methods, and we really like it to, synchronize the follicles. The second is to consider giving androgens in some form. Androgens are also very good. We know that androgens have a paracrine action on the early follicular phase, and it's a substrate for estrogen in the granulosa cell. It increases FSH receptor expression from the two-cell, two-gonadotrophin theory. We know all this, and there is also evidence from primates which suggests that androgens can reduce apoptosis, and it can recruit more follicles if there is a if androgens are given. And how we can boost the intraovarian androgens and increase the recruitment of follicles. One is by testosterone gel, one is by recombinant LH, DHEA. All this is given prior to FSH stimulation of the stimulation cycle, meaning just before the onset of the menses. I think giving testosterone gel is the commonest. We give testosterone gel about 15 to 20 days before an expected menstrual cycle. There have been many people who give recombinant LH 7 days before the menstrual cycle in the luteal phase of the previous cycle. But I have no personal experience with this. Of course, that is added with a depot agonist, and then stimulation is started from day 2. That is one method. Testosterone is something which I have done in the past, and I do quite often. So that is one way. These are the ways in which we can optimize the late luteal phase. And also, like I have mentioned here, is that you could think about giving antagonist premenstrual just 3 days or 4 days before expected menses. Giving antagonist also will suppress this endogenous FSH rise and can lead to better synchronization of the follicles. Now, second is how we can optimize the early follicular phase. Now, that is here. The first 3 to 5 days from day 1. How we can optimize this early follicular phase. Here you can think about a couple of things that one can plan: cycle scheduling for optimizing timing and selected cohort. One can give contraceptive pill, but that is a lot of controversial. Not many people are doing that, at least in a fresh cycle. One can give, one can look at progesterone. One can look at basal hormone levels at the start of ovarian stimulation. Doing an LH, progesterone, and E2 on day 2, how that is helpful, I'll show you. Of course, this is not a regular practice that everybody does. 3 days of antagonist before stimulation, that is also done sometimes. Day 1, day 2, day 3, giving an antagonist, that can be done to delay stimulation cycle, or it can be done if you feel there is a persistent follicle or a corpus luteum or a progesterone is high on day 2, it can be given for that. And then another thing you can do is day 2 antral follicle count every time of a stimulation cycle, because every stimulation cycle can be different, especially in poor responders. One cycle may have just 1 or 2 antral follicles. The next cycle may have 5 or 6 antral follicles. It can be very variable. And one can consider protocols like short agonist, stop protocol, or agonist antagonist with estrogen progesterone protocols. Quickly, I'll try to show you all this. But is there any value of doing a day 2 LH? Yeah, there are many people who believe in it. It may help in many ways. I have written down here for lack of time. Maybe I cannot go through the details. There's many people who do day 2 progesterone levels, because a high progesterone might indicate that you might have a poor response to stimulation and the adverse IVF outcome. And of course, day 2 E2 also is commonly done, and that also has many, possible advantages and implications in an IVF cycle. 3 day of antagonist pre-treatment of, this is what I was talking about. So day 1, day 2, day 3, you give an antagonist, and then only you start stimulation. Of course, the antagonist again will be given later as and when required. The agonist-antagonist conversion protocol. This is popular with some people. Earlier, at least, it was. I don't use this. I have used antagonist agonist conversion with estrogen protocol. So conversion is typically when you give an agonist starting 10 days, day 21, but you stop it as they get period, and then you give an antagonist later. So basically, you give for a shorter while and then stop it. So that is convert to an antagonist, because it might over suppress, given an agonist. Prolonged agonist can over suppress, and then you might require more and gonadotropin. That is the rationale for agonist stop and then converting to agonist. And then E2 priming before gonadotropin further enhances ovarian responsiveness by upregulating an FSH receptor. This is the agonist-antagonist conversion with estrogen priming. It is you give an oral pill, and then you start on with agonist, stop the agonist, give an estrogen, and antagonist, of course, as and when required, and stimulation is started about 5 days later. So these are various protocols that have been used globally by different centers. And then short agonist also we are familiar with. It acts as a flare, and then you stop it, and then you can add a antagonist later. So that is one way you can optimize the early follicular phase of your stimulation cycle. Next comes the preventing the LH surge. There are, apart from agonist and antagonist, today we have the progesterone, but the next speaker is going to speak about this. So let me totally skip through all the all the slides that I have related to PPOS protocol. The next protocol, which seems to be gaining quite a bit of repute, since there is now a significant increase in the number of emergency IVFs, like, for in cases of malignancies and fertility preservation for malignancies, like breast cancer, cervical or uterine endometrial cancer, and many others similar. So this need is increasing, and that has what has led to random start or luteal phase ovarian stimulation. So essentially, it is self-explanatory. You can start, usually FSH is started 1 or 2 days after ovulation, or any day between day 15 to 20. It is, many people give clomiphene citrate plus HMG. Even HMG alone can be given. And there are many reports now available which show you that oocyte numbers, oocyte quality, fertilization rate, embryo formation rate, etc. are quite good. Higher dose of stimulation and longer duration might be needed when you are doing a luteal start protocol. Typically, of course, fertility preservation for post-pubertal girl and women is the commonest indication for a luteal start or a random start. But it can also be done in normal and poor responders if you have less time, or the patient has short time to attend your clinic, and many reasons similar to that. And these studies show that follicular size and the FSH concentration, etc., number of follicles, etc., are quite similar. So one question arises whether luteal stimulation, whenever you're doing, whether you need to add a antagonist or an endogenous progesterone, since it's the luteal phase can block the LH surge. It is reasonable to think that during luteal phase stimulation, both in a spontaneous cycle and subsequent to a follicular phase stimulation, the use of agonist or antagonist is useless and can only raise a patient discomfort, especially in oncological patients. But this point needs to be clarified. So I think in the random start, the preliminary results indicate that the number of total and metaphase 2 oocytes retrieved and fertilization rates are similar, whether early follicular or random start protocols, similar length of ovarian stimulation, and similar gonadotrophin use. Started stimulation on menstrual cycle 11, 14, or 17. Also, the ovary with corpus luteum showed a similar number of dominant follicles compared with the patient's contralateral ovary on the day of trigger. Then we have the double and dual stimulation, which is started in a normal cycle, which is typically called duostim. This is also been there for quite some time. So we are most of us are very conversant with this protocol. So let me not give you the details. Basically, this is the dual start, random start protocol. Dual stimulation in a random start, and this is dual stimulation in a normal cycle, which is duostim. And indications, of course, are poor responders, unexpected suboptimal response in first cycle, fertility preservation in an onco setting. The stimulation regime may be the same or it can be different. Started at least if there are 2 antral follicles are identified. It can be started the second stimulation within 1 to 5 days of oocyte pickup. The second cycle monitoring can be difficult because of the presence of multiple corpus lutea. Second OPU can be risky because again of presence of multiple corpus lutea and chances of bleeding. Double stimulation could be useful also for patients with unexpected suboptimal response in the follicular phase due to inefficient gonadotrophin use. So supposing you've planned a cycle and you've started it and you calculated the starting dose, yet you got a suboptimal response, and so you had very few oocytes. Counsel the patient and you can again start another cycle of stimulation with a higher gonadotrophin starting dose. The other is to move on and perform a second stimulation in case of insufficient retrieval after the first cycle. Shanghai protocol is a specific form of duostim from China, in which typically they use letrozole or clomiphene plus gonadotrophin, antagonist support in the follicular phase, and they use a progesterone or a modified protocol in the luteal phase stimulation. So it is a form of duostim which was typically very, very commonly used in China. This is little different from duostim. In duostim, we have 2 stimulations in one cycle, luteal plus this thing, and we have a specific indication. It can be very variable in terms of drugs, and of course, it has to have a freeze-all approach. Now, trigger matters, yes, in case of M2 oocytes and numbers and quality. GnRH agonist that we have started using as a trigger is a paradigm shift. We all know that there's a lot of difference between the physiology of the trigger and the LH rise in case of an agonist, in case of a natural trigger, in case of a HCG trigger, and in case of a recombinant LH trigger. That we need to understand. They are pretty different, but the closest that comes to a natural trigger is a GnRH agonist. We know all that. And then we have double and a dual trigger. We know that it can improve the double trigger is where because the rationale is that in a spontaneous ovulation is preceded by a surge of both FSH and LH, which is thought to be necessary for final oocyte maturation, as well as cytoplasmic and nuclear maturation and initiation of follicular rupture. Standard IVF cycles utilize HCG as a surrogate for the LH surge. In contrast to HCG, GnRH agonist-induced gonadotrophin mimics the natural mid-cycle surge and exposes the follicle to both LH and FSH. So that is the rationale why this might be this might give us a better, oocyte yield, and specifically M2 oocyte yield. So I think these were my take on some novel protocols. Of course, we know that we still do not have something which is absolutely, which will solve all our problems, and we will still have unexpected poor response, unexpected poor outcomes, unexpected poor rates of fertilization, oocyte, and embryo formation, where we will be disappointed with our stimulation protocol. But that is when we should have enough knowledge and ideas so that we can change our protocol the next time and hopefully get a better cycle outcome. But really, ovarian stimulation is so complex. The more you read, the more you get confused about it. Thank you so much.
Thank you, Sujata ma'am, for that really descriptive and practical lecture, which has loads of experience you have put in into your, tremendous work in the field of ART. We all know what academician you are. So you really told us the pros and cons of all the new technology, new protocols, which we can really follow and which have fizzled out. So madam, thank you so much. And you bring to us a world of experience and lots of take-home points. Thank you so much, ma'am. Always a pleasure listening to you.
Thank you.
Thank you, Dr. Sujata. It was really wonderful talk and various concepts you told, and also the various phases where we should work for to get the optimum result. But as we know that ASHRAE, this guideline says for many things like that antagonist for the first 3 days, or this priming with estrogen, it says that it may not be recommended, like many
Yes.
it says like that.
Yes,
So
absolutely. Because, we still do not, the recommendations have to be based on the evidence that is available.
yeah.
And we have to sometimes individualize our patient.
Yeah, that's true. They can write anything, but we have to
So
see.
what they are writing is absolutely right, because that is based on evidence. This is not something that you have to follow every time for everybody.
Yes.
But for select groups and your patients, you have to opt in.
And I know.
Let's say the 3 days antagonist. Let us say all of a sudden patient got a period and you are not ready. You have to delay something. कुछ है, कहीं जाना है, कुछ करना है. You want to delay the stimulation so that so in that case you have to individualize.
Yeah, what you have to say about the late start of the stimulation? So means from day 4 or so, or day 5, late start. It says that late start is also okay.
So in an agonist protocol, we know that that's not a problem. In a long agonist problem.
Yeah.
But for in an antagonist, in a regular antagonist protocol, I will not wait till day 4, 5. Because by then the FSH would have started rising, and then there will be a disconnect between the follicular growth.
Asymmetry.
So, I will not wait. If I have to wait till day 4, 5, I will give her an antagonist the minute she gets her periods also.
Okay, fine. Thank you, Dr. Sujata.
And suppose we start an antag on day 2, or some people are even starting for synchronization, antag on day 1, or even in the late luteal phase.
Yes.
So in that case, when you are continuing with an antag, can we start stimulation slightly?
No, you have to stop. Yes, you can delay it, no?
Yeah.
What has been shown is usually 3 days. Day 1, day 2, day 3.
But then the purpose of stimulation is lost, na ma'am, because you're delaying it, then you're sort of prolonging the follicular phase.
No. Supposing the situation where we give you, I think you're talking about when you will give antagonist day 1, day 2, day 3, and you'll start the stimulation on day 4.
Yes,
that's what you,
yes.
Now I can think of 2 situations. Number 1, I often do a day 2 progesterone and a day 2 antral follicle count also on the day of stimulation. Now, if you see progesterone is very high, or there is a corpus luteum persisting, you feel that usko thoda sa late, it should fall, the progesterone, by the time you want to start a stimulation, you're fearful of a poor response, then you will give an antagonist for 3 days. That will reduce the progesterone and other things, and then you will start a stimulation. That is one reason. The other thing is, if you want to delay for personal reasons. You want to delay the stimulation from day 4, day 5, not from day 2, because you want to delay the stimulation for some reasons. In that case also you can give. And of course, from the point of view of synchronization, that is also acceptable.
Yes.
But it said that you can go for random start, then why we cannot start from day 4, 5? Means the guideline says that
So
random
day
start
4,
is
when you will start random start, I think it would mean either after day 10, day 11, day 14, like that.
okay. Yeah, we have to do ultrasound, see the follicular condition, and then start.
You should have at least
Like
2
in
small follicles.
PCOS, yeah, if there's no
So what has happened now is, because the stimulation drugs are efficient and you can give any amount of high dose, they will overcome the natural cycle, whatever is happening in this natural cycle. So they will overcome that suppressive effect and they will go on. So for example, when you have started, if you want to random start, by then already the estrogen is rising of the natural follicle that is rising. So you will think it will result in needing more FSH and things like that. But you will be able to overcome because the drugs are so good.
Okay.
There is a question by the one of our audience that for luteal phase stimulation, do you wait for the estrogen levels to fall before starting stimulation in luteal phase?
No, you don't have to do.
Yes.
You can wait, start any time from day after, I think about, usually I'll wait for 48 hours after the egg collection and then start off. But you can start anytime.
Ma'am, you have mentioned in your lecture that if the needle goes into a corpus luteum, there is a real risk of bleeding. Madam, have you encountered bleeding?
I have not encountered personally. Personally, the number of cases that I must have done duostim or the random start, I have never done. But the duostims, I have done quite a few, meaning two stimulations in one cycle. In poor responders, or you get rest oocytes and all that. So I have not encountered. You are careful, and either ways, the number of follicles will not be too much. 2, 3 follicles only on one side. So no, I have not encountered.
Madam, I've started today a stimulation for an onco patient with diagnosed breast malignancy of high grade, and the oncologist has given me 2 weeks for egg collection and subsequent embryo freezing and everything. Do you think I can prolong for 1 week and do a duostim in that case, or should, because the oncologist has told me I should hand over the patient to him within, let's say, 15 days, 16 days?
That is a difficult question. I don't know the answer to that. I think it will depend on what is the patient's stage and things like that. If they have given you time only for one stimulation and collection.
And yes, that depends on the patient's condition, and not only that, extra 1 week may not be enough sometimes. Maybe 10 days more. I mean, minimum.
You need at least 10, 12 days, no, for second cycle of stimulation.
Yes, ma'am. So that will become 3.5.
What is the age?
Age is 37, ma'am.
So either ways.
AMH is 1.14 and she's 37, late marriage, and she just had a hard lump in the left breast, which she palpated accidentally, and it turned out to be papillary duct carcinoma. Yes, ma'am.
What was the receptor status?
And even the patient will not agree, no? Patients, they are more worried about the malignancy than the...
Now the biopsy, no? We all do the receptor status.
So she underwent, this lady, I was very surprised. She underwent an FNAC, which it is not advised nowadays. The findings are from FNAC. Subsequently, she went to a private medical college because she could not afford a total private treatment. In a private medical college, she was advised PET scan, but she said she'll wait till this, egg collection and everything is over before undergoing the PET scan. Because in PET scan also they put those IV, those medicines and all that, sir. So
anyway, she's been scheduled for surgery, so you have to finish.
Chemo, all that combined therapy.
Nowadays, no, if the receptor status is positive, they go for neoadjuvant chemotherapy before the surgery. Then we may not get enough time for
time to do. Yeah, that's true.
Thank you so much, madam. Thank you,
Thank
Faisal sir.
you. Thank you.
Wonderful lecture, Sujata ma'am. Just one question. Did
Yeah.
you find any difference in the oocyte quality during dual stimulation? Like oocytes collected from luteal phase stimulation.
No.
So were they good? No.
I
Same
think
quality.
is whatever experience I have is with poor responders. You hardly get 2-3 follicles in the first one also and in the second one also. But no, do not find any difference in oocyte quality.
Okay.
So
It's
there was
quite
a big hype, Anu. There was a big hype a couple of years back that the luteal phase oocyte quality is better than the follicular
That's
phase.
why I asked this.
No,
Yes.
no.
Just
We
when the
seem to
duostim was
hear
very
so
new
much.
and people were excited
Yeah.
about it, that this thing came up. It's very true. Like Sujata ma'am said, there's actually no difference which we find clinically.
Yeah.
Correct.
Okay, thank you, chairpersons and Dr. Sujata for this wonderful talk. I think went into the almost all the stimulation protocols except the nuclear kid PPOS. I think that will be dealt in the next talk. So we invite the chairpersons for the second session.
Thank you for the opportunity, sir.
Thank you.
Thank you,
Thank you,
Anu.
Dr. Fesi.
Thank you, madam. The second session, invite the chairperson. First, we have Dr. Anuradha Kar from Bangalore. Please show Dr. Anuradha's CV. Next slide, please. Next slide. Okay, and Dr. Anuradha is the Director of Nurture Fertility Center, Bangalore, currently practicing infertility and infertility-related endoscopy at Bangalore, Honorary Treasurer of Karnataka Chapter of ISAR, and the member of Managing Committee of ISAR, Central ISAR for present. And she did MBBS from prestigious King's George Medical College, Lucknow, MD from Srinagar, and fellowship in reproductive medicine from RGUHS, Bangalore, with 20 years of rich experience in field of infertility ART. And she got the Foxy Badilav Award 2024 and several articles in Index Journal. We invite Dr. Anuradha.
Thank you so much, Dr. Fesi.
Our next speaker is Dr. Rendhir Singh. He's no previous slide. He's the. Can you show the previous slide? Okay. She is the immediate past chairperson of MP ISAR and Professor at London Medical College and Director of Bhopal Test Tube Baby Center, Bhopal, and SHA certified embryologist from 2014, and several awards and several publications and several presentations in SHA and ASPARE and ISRM. It is endless. So we are proud to invite Dr. Rendhir to chair this session.
Thank you, Fesi. Thank you.
And our next chairperson is Dr. Shweta Kaur Jha. She is the director of Nirmay Center, Women's Center Indore, Vice President Indore ONG Specialists Association, Managing Committee member of ISAR, Joint Librarian MP ISAR, Managing Committee member of MP IAG, Executive Committee and Convener of Infertility Committee of MPOX, and State Coordinator of Foxy Committee of Midlife 22 to 24 and Infertility at present. And she also had received several awards, including B.N. Roy Gold Medal for All-Rounder Best Student, right from the MBBS time to President Dronacharya Award by the ISAR, and board certified reproductive medicine specialist of FNB and reproductive medicine in Madhya Pradesh. We are honored to welcome Dr. Shweta.
Thank you.
And we call her Shweta. That's why Shweta called Joe is its official name. And we invite the chairpersons to introduce our speaker, Dr. Rajesh Koradia. Over to chairpersons.
Good evening. So, Dr. Rajesh Koradia, sir, is a medical director in the Institute of Reproductive Anesthesia, that IVF Center. He's a very senior obstetrician and gynecologist and infertility specialist, pioneer of IVF and the endoscopy in Mira Bhayanagar region. And he has got a vast experience in the field of evidence-based things and many awards to him. So, Rajesh, sir, the floor is with you.
Welcome, Dr. Rajesh. As I said, your academics and the way you take talk on a particular topic is amazing. We are looking forward to hearing you, and you can start sharing your screen.
Recording in progress.
Am I audible?
Yes,
Yes.
Dr. Rajesh, you are audible.
Yeah, my screen is visible.
Screen I can see. Yeah, PPOS. Yes, it's visible.
It's visible, no?
Yeah.
Okay. So thank you for inviting me at the outset, and it's a really great opportunity for me to present a talk on PPOS on this prestigious platform. Thank
Rajesh
you,
sir,
Dr.
one request to you. Can you make it full screen?
Yeah. Okay, this is fine.
Perfect, sir. Perfect.
This is fine. Okay. So that was a fantastic discussion going on, and we were discussing can we start on day 4, day 5, day 6, something like that. So practically, if I talk about myself, I've stopped categorizing the patient based on their menstrual cycle, and whenever the patient come, I find out the feasibility to start stimulation depends on the size of the dominant follicle, depends on the follicular wave, because as discussed by the previous speaker, the follicular wave differs. Sometimes the AFC is 7 and sometimes the AFC is 12. Because the case we see represented earlier, the AFC was 7 and she got in second simulation, she got 10 blastocysts. So the follicular wave also differs. So we have to chase a follicular wave in difficult scenario. That's one thing. And second thing, the stimulation can be started anytime. The only problem, once upon a time, we were thinking too much about the asynchrony of the follicle and the consequences because of the asynchrony. Now it is proven beyond any doubt, because all the random start protocol, they start with the synchrony and except luteal stimulation. At the most, what is expected is the higher consumption of the gonadotropin, and maybe little follicle output rate is little bit compromised. Nothing beyond that. All the oocyte quality, fertilization, embryo, everything is fine. So we are quite comfortable with the random start protocol, and having the ART bank, we stimulate a lot of donors for other centers also. So the donor not necessarily telling truth. They come at any time. They say it's a cycle day 2. So anyhow, we have to entangle into this the complexity of the random start, and that's how we got experience of random start protocol. Having said that, we move ahead with my topic. That's a PPOS. So before discussing PPOS, we must understand the physiology of the LS surge. We all are almost, I would say, 95% of the ART consultant. If you ask them why LS surge is initiated, everybody will say that it is because of the estradiol level rising, which causes positive feedback, and that's how the LS surge is initiated. It's partially true, partially wrong, because it is not only the estradiol. The P elevation at the same time is also equally important. That gives signal to the hypothalamus, and hypothalamus changes the pulsability, and then sends the signal to the pituitary, and then that's how the LS surge is initiated. Now, I am not going into the detail why progesterone is elevated and how much elevation is required for initiating the LS surge, and because that's an endocrinology talk. I don't want to enter into that. But briefly, the progesterone elevation is equally important. So, having said that, progesterone elevation is important for initiating the LS surge. How progesterone prime protocol can be used, because progesterone itself will act as a trigger. So that we'll discuss little later on. So, but why we are worried so much about the uh, prevention of the LS surge? Because of the premature LS surge, there are chances of progesterone elevation. There are chances of premature ovulation, and because of that, maybe cycle cancellation. The oocyte quality may be worsen. We all understand, and we almost all presume that if the progesterone is elevated on the day of trigger, and if we freeze the embryos and we transfer in the frozen embryo transfer cycle, absolutely, it is absolutely fine, and it is not going to affect the outcome of the cycle, which is not completely true, because everything has a limit. So if the progesterone is elevated, say in normal responder I'm talking about, if it is elevating beyond 2.25, then even with that high progesterone in normal responder on the day of trigger, if the embryos which were frozen formed by those oocytes doesn't give enough success rate, comparable success rate. So we have to be very judicious in giving doses of the gonadotropin also, and we have to be very reasonable, because after the Sunkara's paper, everybody started thinking that cumulative live birth rate out of one stimulation is directly proportional to the number of the oocytes what we have retrieved, and up to the, of course, up to the limit of 25. And there is no harm in giving higher dose of gonadotropin. Yes, partially you're right, but we have to be same time judicious. And because of this premature LSS, there may be suboptimal fertilization. So then what is the role of progesterone? The progesterone suppresses this GnRH secretion. It has got hypothalamic action. And if I talk about the action of progesterone in suppression of the pituitary or downregulation of the pituitary, then we all understand that once we give either OC pills or a progesterone pill, tablet of progesterone, the pituitary complete downregulation takes 5 days. So after 5 days of progesterone, you can expect that pituitary, now there will not be, the pituitary is absolutely downregulated. But here, our aim is not a downregulation of the pituitary. Our aim here is reduction in the LS surge. So interestingly, the progesterone, if you give progesterone, and if the progesterone is somewhere around causing the serum level between 0.8 to 1 or maybe little more than 1, it starts altering the frequency of the GnRH. Can you mute somebody? The mic is, I'm getting disturbances. Please mute your mic. Okay. So sorry. And this happens within a few hours of administration of the progesterone. So once you start progesterone, within few hours, the GnRH frequency starts altering, and which will result in the reduction of the LH frequency, which will inhibit the mid-cycle LH surge, and which will create the functional pituitary suppression, not downregulation. Maybe downregulation in next 5 days, but suppression maybe in 1 day only. So how the PPOS concept came? It came from the natural model because they started with the luteal stimulation, and they found that luteal stimulation, there is already progesterone is quite high in the serum, as well as in the in the serum, and still the oocyte qualities are unaffected. So that means the progesterone is not affecting the oocyte quality. High progesterone level does not affect the oocyte quality. So the second evidence came that if we, during the follicular stimulation, if you measure the progesterone level in the follicular fluid, which is much, 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 much higher than what is there in the serum level. So progesterone level does not, or progesterone itself does not affect the oocyte quality. So that's how the concept of progesterone prime protocol came into the action. So the initial paper, because the first paper I read, I started implementing progesterone prime protocol in my practice. And the very first paper, when it came, they suggested that when you want to do a progesterone prime protocol, you have to measure serum E2 level before starting your stimulation. Why? They put forward the logical explanation for that. They say that if the serum estradiol level was more than 70, and if you start progesterone prime protocol, in fact, it would increase the chances of premature LS surge, which was completely proven wrong later on. Because as I said, what they understood, they assumed that 70 picogram of estradiol will become 140 in 48 hours and 280 in 76 hours. So then there are high chances of LS surge because already the estradiol has crossed 200 picogram, and if that high level remains for more than 50 hours, we all think that the LS surge is likely to happen. But that does not happen. Why? Because the progesterone, the moment you give progesterone, it alters the frequency of the GnRH within few hours only. So you have to forget about the LS surge. There is no chance of LS surge. So initially, this logic was put forward, and then whatever the later study came, then that part was removed as a methodological part was removed, and they said there was no need to do estradiol level before starting progesterone prime protocol. So what are the different methods? Normally, most conventional method, everybody prefer to start progesterone along with the gonadotropin from cycle day 2 or 3 whenever they start stimulation. And another way is a flexible start protocol where the progesterone is start exactly like antagonist. Whenever all the criteria of starting antagonist are met, the progesterone in the similar fashion to be started. So that's a flexible PPOS, and one is a standard PPOS. Of course, there are other ways of also PPOS. You can give a PPOS in luteal phase also. In luteal phase, out of insecurity, people give progesterone. That is one reason. And second reason, in luteal phase, the reason for giving progesterone is to avoid menstruation. And that should not fall at the time of ovum pickup to avoid inconvenience. So that's another reason of starting having a luteal PPOS. Only one study said that if you use PPOS in luteal phase stimulation, the chances of LS surge is almost zero, and which is not there if you do not use. So that's fine. It's very negligible difference. So in my practice, I never use PPOS in luteal stimulation. I just go give gonadotropin and straight away go give trigger. So this was a luteal stimulation. And of course, in random start also, of course, that's a different lecture, only random start protocol. In that also, one of the strategy in random start protocol for uh, prevention of the ALS surge is using PPOS. So the endometrial effect, obviously, it has to be there, and it causes decedulation of the endometrium. But because the estradiol level is not sufficient to induce progesterone receptor, there is a disrupted receptivity, there is a asynchronous glandular development. So patient is not fit, window of implantation is shifted, and patient is not fit for fresh embryo transfer. So you have to freeze the embryo. So this we have already discussed type of the PPOS. The how PPOS differ, because here instead of injectable we are using oral. The LS suppression is central at a hypothalamic level, and we cannot transfer fresh. So what are the dosing and preparation of the progesterone? So practically, the original study, they used medroxyprogesterone 4 milligram. The first study of PPOS came, they used 4 milligram of the medroxyprogesterone. And 4 milligram medroxyprogesterone is not available in India. So normally for convenience, we use 10 milligram. One of the company was having 5 milligram earlier, but then I think it's not there. As per my knowledge, it's a 10 milligram. So for many months, we have been using medroxyprogesterone 10 milligram. Now I have switched over to micronized progesterone or dydrogesterone for some reason, definite reasons. So so medroxyprogesterone can be used 4 to 10 milligram, dydrogesterone 10 to 20 milligram, and micronized progesterone 200 microgram is sufficient for the suppression. Of course, in this table, they have mentioned higher dose for ovulation inhibition dose, but then this much higher dose in practicality is not needed. Dydrogesterone 20 milligram per day is just sufficient, and medroxyprogesterone 10 milligram and macronized progesterone 200 microgram. So depends on what type of PPOs, we can start accordingly. So now let us compare. The next questions come, because we all are very much accustomed to what has been taught to us during maybe a fellowship or whosoever mentor is there. So if your mentor is of conservative mind, then he will think 100 times before accepting PPOS as a standard protocol and accept it very warm-heartedly. So if you compare PPOS with the antagonist, there is no difference in the cumulative pregnancy, live birth rate, miscarriage rate, multiple pregnancy, everything same. But the cost in PPOS is lower. Now I have caveat for this. The higher patient acceptability agreed, OHSS rate same except one study. So the earlier study said that in PPOS, actually you are not saving, because the gonadotropin required maybe somewhere around 400 unit more, and the stimulation lasted for 1 to 1.5 days more. So actually you are cutting cost of 3 or 4, I mean 4 or 5 antagonists. Instead of that, you are adding 3 injections of gonadotropin. So actually there is no significant cutting of the cost. And second thing, you cannot transfer fresh. So again, freezing charges, freezing and thawing charges are applicable. So actually it is not a lower cost, but definitely it's quite convenient for the patient because it reduces the number of the injections. So it's quite convenient. So the PPOS significantly suppresses the premature ALS surge. If you compare it with the antagonist, 3.1% versus 20.1% in antagonist group, the incidence of the ovulation prior to retrieval 0% versus 0.5% in the antagonist group. In the some study, good quality cleavage embryo rate were lower in PPOS compared to the antagonist. And so these are the only 2 studies, and this is especially when you use dydrogesterone in elderly patient. Then this happens. The good quality cleavage embryos rate were lower, but the rest of the places it is fine. In the same study, the birth, but there is one more study which says that cumulative live birth rate out of one stimulation is marginally reduced in PPOS. So these are the only two negative study which drew my attention. Otherwise, all other studies says that either it is a beneficial or it is same like antagonist. So in the same study, live birth rate following first PPT was lower in PPOS, 31.5% versus 42.3% in antagonist group. Implantation in biochemical and ongoing pregnancy were lower in PPOS. So this is the paper where the paper conclusion is talking against the PPOS. So what about the agonist? So overall outcome is similar, but PPOS use significantly lower gonadotropin consumption than long agonist protocol. Significant higher gonadotropin consumption than short agonist protocol. The clinical pregnancy rate were significantly higher with PPOS. In women with PCOS, clinical pregnancy rate were also higher versus the short GnRH agonist protocol. But 647 units more gonadotropin dose and 2.4 days more stimulation required in agonist protocol compared to PPOS. So obviously, if you compare it with the long agonist protocol, it is definitely economical and advantageous. Now, second question comes, we should go for conventional start or we should go for flexible start. So the people are really hesitant to switch over to PPOS, and still I'm sure will be more hesitant to go for the flexible start. But believe me, the flexible PPOS, the most advantage of flexible PPOS is many times before when we start stimulation, we are not sure that we are going to transfer fresh embryo or we are going to freeze the embryos. So the flexible start gives a flexibility. So when you start stimulation and then a lot of follicles, say for more than 12, 13, 14 follicles are recruited, then you would not like to transfer fresh. So you can start, instead of antagonists, you can start progesterone and you can freeze the embryos. But if you think that, yes, the number of the follicles recruited are less than 10 and you want to take a chance of fresh embryo transfer, then instead of progesterone, you can start antagonist. So that gives the flexibility. That's the most important advantage of this. But the overall stimulation outcome seems similar between both PPOS, whether it is flexible or conventional. The flexible PPOS may yield similar cumulative live birth rate to conventional PPOS in poor prognosis. Now, if you ask me, the flexible start should not cause any extra chances of premature LSH because within few hours only the GnRH pulse is altered. So there is no chance of premature LSH. On the contrary, I prefer to have flexible start protocol in, I would say, normal responder patient because there is no much LH suppression. The LH remains quite decent till maybe late follicular phase. After that, the suppression starts. So this is fine, flexible for normal responder. Now, second question, if you compare the flexible start versus flexible antagonist protocol. So the number of the COC retrieved were similar in both group. The number of the mature oocytes were also comparable. And the duration of the stimulation was comparable. Total gonadotropin consumption was similar between the protocol. No cases of premature ovulation observed in either group. And this was absolutely, this study was using dydrogesterone. And there is a significant cost reduction. So it's a good strategy to have a flexible start antagonist protocol. Now, comparison with the dose, we have already discussed the dose. So patient selection, the extreme of reserve are the good candidates. So PCOS, very good and poor responder. They are the two good candidate to for the PPOS. The fertility in poor responder, especially when you are not planning for breast transfer, you want to just accumulate the embryo, then the PPOS is the ideal protocol. Apart from that, the standard fertility preservation oncology patients, oocyte donors, and freeze all cycles. So in practically in my RT bank, for all oocyte donor, we use PPOS. But it has to be avoided when you want to transfer fresh embryo. If there is a progesterone hypersensitivity, severe liver disease, there is unexplained recurrent follicular arrest, and last but not the least, the progesterone receptor positive breast cancer patient, you should avoid PPOS. So how is the hormonal dynamics? There is a suppression, LH, gradual E2 rise, it's not affected. There is gradual rise. There is elevated progesterone and there is absent LH peaks. Now, elevated progesterone serum level, which is reflected in serum level when you are using medroxyprogesterone or micronized progesterone, which does not happen significantly when you're using dydrogesterone, because dydrogesterone level does not reflect in your serum estimation of the progesterone. That you have to always remember and understand. How was the follicular growth? Absolutely fine. There was no problem. Trigger, any trigger you can use. See, when we use antagonist protocol, we are quite scared to, after last dose of antagonist, we keep, I mean, a lot of my followers keep asking, within 4, how much gap should be there? So our standard teaching was at least 8 hours gap should be there. But there are recent study which says that even after last dose of antagonist, you can give agonist trigger immediately, because the agonist has got a higher affinity to the receptor and it can easily replace the antagonist. So you can easily give. But still, including me, most of us are worried to give agonist trigger immediately. But here, that is not a case when you are using a progesterone prime protocol. Anytime you can give up, even of the last pill of medroxyprogesterone immediately, you can give agonist trigger, you can give SCG trigger, you can give dual trigger. So that flexibility is always there. But you have to think twice when it was a case of hyper responder. So there are some concern about the trigger to retrieval interval, but later on it was concluded that there is no difference. The only difference is the duration, maturation rate is increased by 1.2% per extra days of stimulation. That is all. Rest everything, there is no difference in the trigger to oocyte retrieval hours. So lab results are absolutely similar. Clinical outcome similar. Advantages, oral drug, low cost, we all know. Limitation, primarily you have to freeze the embryo. And we do not have long-term data. So now if we compare the young and elder people, then what is the difference? Is PPOS is good? So PPOS, if we talk about the older patient, the PPOS significantly increased the euploid blastocyst rate per M2 oocytes. That's a very good thing. The PPOS euploid rate per biopsied blastocyst was significantly higher. Very good. The mosaic blastocyst rate was significantly lower with PPOS. Still very good. PPOS, so PPOS is suitable particularly for older patients for higher euploid rates. Now, what explanation put forward for this is because this study they tested medroxyprogesterone. So what they hypothesized that when you use medroxyprogesterone, all the metabolites of medroxyprogesterone are having androgenic effects. So because of the androgenic effects, the follicular sensitivity towards FSH, is increase, enhance, and because of that, probably follicle output rate and maybe euploidy, there is a more androgen, there is less apoptosis. So probably that's the only explanation which is put forward. But what about the euploidy in younger patients? There is no significant difference in euploid blastocyst rate between the protocol. So in younger patient, there is no difference. Everything was same. So the proposed mechanism we have already discussed. So now a very interesting the concept which I like to use CC in PPOS. So we all know CC cycles, they are characterized by higher FSH and LH level all throughout the stimulation in luteal phase, follicular phase, as well as the luteal phase. And our main problem with the medroxyprogesterone PPOS is too much suppression of the LH. So if you want to counteract this, if you want a good LH activity, and still if you want PPOS, then this is the right solution. Use CC for 5 days. And what has been observed when you use CC along with the PPOS? The PPOS plus CC resulted in a lower percentage of profound pituitary suppression. What do you mean by profound suppression? LH less than 1 on trigger day. So overall suppression rate was found 0 to 1.3% in PPOS plus CC versus 11 to 18.6% in standard PPOS. So suppression is positively correlated with the GNH, gonadotropin consumption. So it's the right thing to use CC when we are using. We are not worried about the endometrium because CC, otherwise we always start talking about the adverse effect on the endometrium. Here, anyways, in PPOS, we are not going to transfer fresh. So we are not worried. So then hormonal profile, when you give CC, the LH levels were significantly higher on day 7 to 10 and trigger day, remain steady 5.52 to 6.61. So it's a good. So what is the outcome in young woman when you use CC? So PPOS plus CC had a positive impact on high quality embryo for younger women, but same is not true with the older woman. You have to be very careful because it was observed that in elderly woman or diminished ovarian user, poor responder woman, the chances of LH surge was higher. So, so this is the hormonal level. You can see the LH level remains high. So in older women, LH surge chances, incidence of high LH was 12.7% in PPOS plus CC versus 4.9% in standard PPOS. And PPOS CC lead to decreased rate of oocyte maturation in older women. So you have to be careful in using CC with PPOS in elder women. Okay. So, but in younger women, everything is fine. Gonadotropin duration dose were substantially statistically similar across the group, and better outcome for younger women. So it's not ideal to use CC in elder women. The safety data, this was a overall conclusion of the majority of the studies. No increase in the congenital anomalies, no impaired embryo competence, and safe hormonal recovery. But there are contradictory studies published. So what they did, the single cell RNA sequencing was done on mural granulosa cells. And what they found that they showed higher expression of the 12 mitochondrial DNA genes. And this is directly related to the oxidative phosphorylation. So increased mitochondrial DNA expression was confirmed. And this is because of this reflects the oocyte quality. It is suggestive of the impaired oocyte quality. So caution should be exercised when employing the PPOS or ART. There are some concerns. But overall, so far, the experience till now is good. We are not gone into such a molecular level, so probably we do not know what is right. The oocyte from the PPO cycle have similar fertilization, lustrulation rate, euploid rate similar. Most study reported comparable euploidy rate. One small study suggested lower euploidy rate in older PPOS patients, whereas another study suggested higher euploidy rate. So there are contradictory findings are there. So what are the special group? PCOS, poor responder, and oncology group are the ideal. The cost, as I said, that actually you are not saving the cost because compulsorily you have to freeze the embryo. So when you want to freeze the embryo, elective freezing, then this protocol is economical, otherwise not. These are the recent few studies, recent literature. Random start progesterone prime ovarian stimulation using oral natural micronized progesterone versus basal start gonadotropin releasing GnRH antagonist. So random start progesterone prime versus antagonist, basal start antagonist. So what has been observed that it has allowed the maximum treatment flexibility and ovarian response rate was comparable between random start NPPOS and the conventional GnRH antagonist protocol. So meaning the inference is if you want to do a random start protocol, you can put the patient on progesterone and you can go ahead with the stimulation. The results may be almost equal. The second study, which compared the dydrogesterone versus medroxyprogesterone for the patient undergoing in vitro fertilization, comparing dydrogesterone versus medroxyprogesterone. So they said everything is same, with the dydrogesterone potentially offering a more physiological hormonal profile and reduced gonadotropin use. So in my practice, most of the time, I stopped using medroxyprogesterone because I do not want too much LH suppression. And so that's the reason I do not want to use medroxyprogesterone. So either I use micronized progesterone if it is an elderly patient, or it is a dydrogesterone in rest all the patient. The beauty of the PPOS is a very severe PCOS. In severe PCOS, because the basal LH level is quite high, so either you have to pre-treat to make it more stimulation friendly. You have to pre-treat with the either antagonist, and the alternative is you can start progesterone. You can continue progesterone maybe 2, 3, 4, 5 days, and after that, if you start stimulation, continuing progesterone, then this PCOS, severe PCOS, which is normally phenotype 1 and 2. I'm talking about phenotype 1 and 2, which are oral drug resistant and gonadotropin consumptions are quite high, and they are poor responder PCOS. So then the stimulation becomes more friendly. This is another study. The fewer good quality cleavage embryo, which we have discussed, dydrogesterone prime stimulation compared to antagonist in Poseidon group 4. So in Poseidon group 4, normally I use micronized progesterone. The follicular output rate was improved with 3 days letrozole administration compared with the 5 days letrozole administration under progesterone prime protocol. So they compared 3 days administration versus 5 days, and especially in poor responder, we sometimes tempted to transfer fresh, and evidence also suggests that. So whenever such possibility is there in your mind, always combine anyway, sorry, I'm really sorry, progesterone prime protocol, it's out of question. But if you really want to reduce the dose, then letrozole protocol, you should combine with the progesterone prime protocol. So the most of these studies were non-randomized and conducted by a few Chinese group. Live birth rate were reported per transfer, not per woman starting stimulation. Cumulative live birth rate not reported at all in most of the studies. Many competitive trials were underpowered for key outcome like live birth rate. The overall evidence quality is low, especially for embryo transfer outcome. So I cannot say that it is absolutely 100% safe protocol But so far, so till now, we are getting, we have used in lot many patient, thousands of patient, including donors, and wherever we send a donor, they are quite happy with the results, and there is no problem. Initially, when we started progesterone prime protocol, our embryologist used to say that what do you call the cytoplasmic oocyte cytoplasm viscosity was quite high. It was quite viscous, and she was facing difficulty in ICSI. So I started having doubt about the oocyte quality. But in none of those patients, the embryo quality and implantation rate was affected when we transferred frozen embryos after thawing. So overall, we are quite happy with the progesterone prime protocol, and definitely you should switch over to progesterone prime protocol whenever it is indicated. So this is, I end my discussion with this, and all any questions are welcome.
Thank you, Dr. Rajesh. It was a wonderful and excellent presentation. I have one question because you said that you're using even micronized progesterone.
Just a minute, madam. Let me stop. How to?
Yeah. So you
broadcast how to stop.
Yeah.
It's fine now. Okay.
Yeah. Okay. So
Fine.
So Dr. Rajesh, I have a question. You said that you are even using micronized progesterone for the
Who responded? Poseidon 4.
For as PPOs. But if we compare, I have a question that micronized progesterone oral bioavailability is lesser than dydrogesterone, and that's what we have been we have learned, and we've been, so that is how we shifted, even as luteal phase support, we almost have shifted from micronized towards dydrogesterone. So, but you are saying no, you can use 200 micronized progesterone. What is your take on that? I mean, is there a concern we should have for absorption? And you said you've had good results, so I would like to ask that question.
So the same question was there in my mind. So I asked AI. I asked the question within. I asked the question. I'm saying what AI says. How early oral progesterone alter GnRH pulse? Okay.
Okay.
So what is the answer? The progesterone is a powerful negative regulator of the GnRH pulse. That's fine. That's fine. The progesterone binds to the progesterone receptor. It increases this, and there is reduced frequency. Within 2 to 6 hours of progesterone exposure, the GnRH pulse begins to slow. Now, why oral progesterone works even with the lower serum level? That's the answer. That's interesting to know. The oral dydrogesterone and medroxyprogesterone have high central nervous system penetration. There is a strong binding to the hypothalamic receptor. Even serum level as low as, say, for dydrogesterone, 3 to 5 nanogram per ml. And if you consider active metabolite, 50 to 60 nanogram. And medroxyprogesterone, 1 to 2 nanogram is enough to inhibit the GnRH generator. Okay. Now I'm talking about
the micronized.
So threshold central suppression begins at 0.8 to 1 nanogram serum progesterone, and for complete LH surge prevention requires more than 1.5 to 2 nanogram per ml. So both the oral progesterone achieve suppression at very lower serum level because of the strong central penetration. So that's the reason. That's the reason. It can be used very safely.
So, the answer to this question, what you are giving us, is that the suppression occurs at a very small level. Whereas if we compare the luteal phase support, that needs a higher level to support the luteal phase, and that is why probably we have shifted there towards more towards dydrogesterone or vaginal microprogesterone compared to this. So I think I got my answer. Thank you so much.
Yeah, yeah.
Any other questions?
Wonderful lecture, sir.
Thank you.
So just one question. Do you take any extra consent, like as you said, PPOS in PPOS way, it is off-label use, na? So should we take any extra consent while using PPOS protocol?
I don't take, but if you see how many consent to take, the patient will become, frightened. If you, then they will have 10 more questions. So it is fine. Lot of things of label we are using. This is fine.
So I have one more concern when it comes. I mean, yes, oral is patient friendly and all that, but maybe that patient will forget to take the tablet. Injection, we are very sure. I mean, I'm talking about pro for the injection, that the antagonist injection, I'm very sure she comes to me or my center and she knows she has to take the FSS shot or the LS shot and the antagonist shot. I am 100%, I sleep well. Whereas in the dydrogesterone or other forms, non-injectable forms, I will always be worried about that, whether that patient will take the tablet on time or not.
So a very good question,
What do
madam.
you do?
So
What do
what?
you do?
Yeah. So there are two options. With patient come to your center and take it for the injections, and second option, you give them injection in a parcel, the box, ice box, and then they take somewhere nearby. But whenever we explain the patient how to take injection, how to preserve the injection, all those, our first sentence: without this tablet, you cannot take injection. Without this tablet, you cannot take injection. And you set a alarm to take tablet and injection. So then they normally do not forget that one thing. And if they come to my center without even my receptionist, who doesn't understand PPOS too much, but she knows, okay, without tablet, injection cannot be given. So first she will give tablet, and then she will give injection. The second thing. Second thing is the second explanation. If you look at the basic physiology, once the pituitary is down-regulated, say maybe after 5 days of progesterone, and even if you stop progesterone, the pituitary recovers after 5 days only. Next 5 days, you are safe as far as the LS surge is concerned. And anyways, we have seen that very low level of progesterone level is required for the prevention of the LS surge. So it's fine. Even if a single day, if you forget, it's fine. It's absolutely fine.
Good evening, Dr. Kuradia. This is
Good.
Dr. Shweta here.
Hi.
Sir, hello, sir. So, in which patients of yours you are using PPOS protocols?
I use PPOS in all patients where I have decided clearly I'm not going to transfer the embryos fresh. Now, what are those patients? So primarily, I decide on antral follicle count. So if the antral follicle count is less than, say, 12, 13, AFC less than 12, 13. If it is less than 12, 13, then I consider that if I stimulate that patient, then I will get somewhere around 9, 8, 9, 10 oocytes. And if I get 7, 8, 9, 10 oocytes, I'm sure that progesterone will not be too much elevated, and I will have a chance to transfer embryo fresh. So this is the only scenario where I would use antagonist. Otherwise, in rest all cases, I use progesterone prime protocol.
That's excellent.
Sir,
It is
does
also a good option.
PPOS, sorry,
Yeah,
I'm
yeah,
so
yeah.
sorry.
Monica. Yeah,
Yeah. So I just wanted to ask you, sir, my experience with PPOS is very minimal because I heard some conflicting statements about the outcome, as happens with anything new. But what impresses is the ease of use and, of course, the economy. But having said that, there is literature wherein the excessive suppression has led to a gonadotropin consumption increase to the tune of 33% per patient per cycle. Is that true in your clinical experience?
See, normally we use, I have, after the paper of Sankara, I have revised uh, my strategy of starting dose gonadotropin. I've increased at least whatever is suggested by David Gardner, considering various things like ovarian reserve markers, age, then what you call previous stimulation protocol, how much gonadotropin was used, then any fibroid or endometriosis, adenomyosis, any peritoneal disorder, and depending on the responder. So whatever criteria are set till now, after Sankara's paper, I have increased the dose by 75. So I have tendency to use little extra gonadotropin. And normally I use a very economical gonadotropin product which are made in India. Till now, I have not seen how Menopur looks like. Believe me, I have not seen how Gonal F looks like. I am very happy with biosimilar. I am very happy with the Indian standard HMG injection, and I'm able to deliver the result. So my cost of stimulation is hardly 7,000, 8,000 rupees. Doesn't matter much to me, even if little higher dose of gonadotropin is used. So I do not worry much about that.
Yes, agreed, sir. So suppose you are, spending wisely on gonadotropins, then a little bit of increase of dose really doesn't matter, where you have already decided that you're not going to do a fresh transfer.
Yeah.
When it is pre-decided, then of course stimulation becomes programmed, it becomes reasonable, feasible, and you
Yeah.
achieve the goal that you want to, achieve.
Absolutely. So I'm very much happy with one more criteria of whenever I wish to transfer fresh, then I make sure that my gonadotropin consumption does not cross more than 2,500. So in other words, I use milder stimulation or moderate stimulation, not exactly milder stimulation, moderate stimulation protocol. Because if my gonadotropin consumption crosses that, then probably I am not happy to transfer AmbuFresh. And there is a literature backup evidence that if your gonadotropin consumption is more than 2,500, then your fresh transfer outcome are going to suffer. So I also follow that.
Very true.
So if you won't mind, what is the pregnancy rate with these protocols? And if sometimes you use this and patient has failed, does it come to your mind to use the conventional thing in them?
Frankly speaking, whenever we normally transfer either 2 blastocyst or 2 to 3 cleavage stage embryo. Our average clinical pregnancy rate is somewhere around 65 to 70%. Whenever the pregnancy rate has dropped, it is never because of the stimulation strategy. I am a strong believer, and that most of us clinician, we try to blame injection, we try to blame protocol, we try to blame everything what we have done, but we never blame embryological protocol. We are ignorant what is happening in the lab. We are ignorant on how embryologist is working. on your eggs. So whenever the results have dropped, then we have started cross-checking. We always found something wrong with the calibration or maybe media pH or something calibration of CO2 or O2. So I'm sure that a very small difference uh, is made because of the choice of protocol or choice of the gonadotropin injection, according to me.
Actually, sir, we don't have experience in this
Also,
protocol, and your
Dr.
talk have
Rajesh,
definitely us,
whatever,
and we would definitely like to use.
Sorry.
yeah, I mean, and we just transfer the embryos, which were looking good. Definitely, you have done an embryo transfer, but we do not know the, genetics or the chromosomal aneuploidy and all of that embryo. So we do not know, even a good-looking embryo can have, problems. It could
So
not be an implied embryo. So we always blame our protocols, our injections, our triggers, in the beginning as a beginner.
No.
But we do not know whether those embryos, even if they are good looking, whether they are euploid embryos or the
No, sir,
inherent.
you only quoted some study that some oocyte related issue was there. You only quoted some study.
yes.
So when you know something is like this controversial, when you know this is not this is being used off label, I'm just curious to know that what gives you dedication. This is the cost cutting.
But euploidy rate is always same. Many times they have tested by doing PGT of all the embryos which are formed out of progesterone prime protocol, and they found absolutely same. So euploidy rate is not different. So that oocyte quality, see, it is similar to something like in endometriosis. Are you sure the oocyte quality is going to be good? But still, what study says that in endometriosis, even though oocyte quality is not good, euploidy of the oocyte is equal and blastulation rate is equal. What a contradictory statement. Conclusion, I would say.
Interesting, sir.
Absolutely.
We would like to use, and we'll get in touch with you, sir, also.
No, if gonadotropins were in continuation with what you said, if gonadotropins were really going to determine.
No, before that, madam, before that,
Yeah,
you
yes,
talk
sir.
about the embryology, the morphology of the embryo which we transfer. So now of late, I have started giving importance to morphokinetics more than morphology. So in my center, my daughter is my embryologist. So she has to follow whatever I say. So she follows. But it is same. Everybody did not have that capacity to, ride embryologists, because many a time in a smaller center, embryologists are boss. They advise the clinician, oh, इसका freeze कर लेते हैं, इसका ट्रांसफर डे 3 में करते हैं, कभी बोलेंगे डे 2 में करते हैं, कभी बोलते हैं इसका ब्लास्टोसिस बनाते हैं, कभी बोलता है नहीं अच्छा नहीं है, उसको फ्रीज कर लेते हैं. मतलब उनको दिमाग में जो आया, whatever they according to their convenience, their workload, they try to manipulate you, which does not happen in my center. So I completely I do not have time lapse incubator, but I always have timetable, and I always make sure that I want to transfer the embryo which has got best morphokinetic score and morphology simultaneously.
So you are checking them daily physically?
Yes, my daughter is checking. Yeah.
Okay, sir.
So your daughter is the time lapse there.
Yeah.
That's a good way, actually.
Yeah. Not daily checkup is, madam, not required. Basically, day 1 fertilization check and then day 3 check is required. Then after that is not required.
Excuse me, sir.
Yeah.
If a patient is on this progesterone protocol and she's taking regularly the tablet at a particular time, like 8 p.m. And we are planning to give the trigger on next day, like at 10 p.m. So in that case, should we repeat the tablet or it's not required?
Actually speaking, not required. But even if you repeat, it does not harm.
Okay, so after 12 hours, like in the morning, you can repeat the tablet.
Absolutely, because even if after stopping the progesterone, the pituitary takes 5 days to recover.
Yes.
So even if you do not give progesterone tablet on last day, it is fine. If you give, then also it is fine.
Okay.
Yeah.
Thank you. And sir, with medroxyprogesterone, what you said, it's I also experienced that with medroxyprogesterone we need more the dose of
Gonadotropin.
gonadotropins as compared to dydrogesterone.
Yeah.
That is very
So
true.
otherwise, also dydrogesterone is a weak LH suppressor,
Yes.
and that has been proven. Even Dr. Prakash Trivedi published paper long back. In endometriosis, he was suggesting to use dydrogesterone, and what he proposed that if you give dydrogesterone, the ovulation is not inhibited, and patient can become pregnant even on dydrogesterone.
Yes.
That is little difficult to believe, but that gives a idea that dydrogesterone is a weak suppressor of LH for sure. But still, the LH surge chances are 0 or as equivalent to antagonist or medroxyprogesterone. So that's a good thing, ne?
Yes.
Yeah.
Yeah.
Thank you, sir.
So, sir, the ideal dose, I missed that portion. The ideal dose of dydrogesterone would be
10 milligram BD.
BD.
So in many patients, I give single dose ER. Then now extended release tablet is also there, 20 milligram.
Yeah.
So sometimes give ER 20 milligram tablet or 10 milligram BD.
Okay.
Sir, for this natural micronized progesterone, if we give the vaginal, then 200. And is there any role
No, it is, I give orally because nowhere it is, oral. Because in following vaginal insertion, the serum levels are still, not sure.
Okay, sir.
Dydrogesterone, you said 20 ER. Dydrogesterone ER 20 milligram OD or plain 10 milligram BD. Okay.
Yes.
Okay, I think
You're using oral progesterone because you want the serum levels to be consistent rather than the vaginal administration, which will lead to more of local release.
Yeah,
Serum
absolutely.
levels may be inconsistent.
Yes. Yeah.
That's really rational. Yeah.
are there any questions in the chat box?
I'll just check.
I don't think.
No, sir.
I am in a mobile, so I can't.
So one question, please.
Checking.
So one question, please.
Yes.
Sir, you were mentioning about the total gonadotropin dose and the success rates in fresh transfer. The total gonadotropin dose not to cross 2,500 units. But I couldn't find any paper regarding the total gonadotropin dose and the fresh transfer. Maybe the E2 levels and the fresh transfer.
No,
Can you please elaborate?
I will send that paper. Anupama, ne?
Yes.
Yeah.
So
I
because
will
most of the times poor responders, we start with 300 units and we do a fresh transfer with where the total gonadotropin dose may be 3,000 or 3,500. And
So, in any literature, in any paper, if they suggest something regarding the dose, they are based on RFSH. So I consider 2,500 RFSH is equivalent to somewhere around 3,000 of HMG. The stimulation potential of HMG is little lesser as compared to RFSH. Potency, stimulation potency.
Okay.
So 3,000 is upper limit.
Sorry, sir.
3,000 is upper limit.
Okay. Because poor responders, we reach 3,000 units and we do a fresh transfer.
Yeah.
Thank you.
So in poor responder, I never, if I intend to transfer fresh, I do not cross 300.
Yes, sir.
But yeah, but if the idea is to accumulate the embryo, then maybe Poseidon 3,
Dr. Andir here.
I'm tempted to give more.
Okay.
Yeah.
Thank you, sir.
Thank you.
There's a question, Dr. Rajesh, that in
Yes.
random start protocol, how to proceed with PPOS? Somebody has written a question.
It will take at least 10 minutes. Is it fine?
Yeah.
Yes, sir.
Okay.
Dr. Anu, we can have 10 minutes?
Yes, sure.
Yeah, thank you.
Please repeat the question, Anu.
It is that if we are doing a random start protocol, how to use the PPOS protocol there?
Okay. Thanks.
It's a good
Okay.
question, actually.
Yeah. So most of us are not used to random start protocol because our standard learning is when you use random start protocol, when the follicle is already recruited, dominance is acquired, and that will prevent the growth of the other follicle and this and that. Cycle outcome is going to suffer and this and that. That was standard learning till now. But a couple of papers, they have proved that even in the presence of asynchrony, and which is a very common phenomena in random start protocol. Even many of those studies says that even gonadotropin consumption is also same. Rest everything is same. Oocyte quality, number of the oocytes, fertilized, everything is same. But practically, what I have understood is gonadotropin consumption is little more, and the cycle length, stimulation days are little more. Rest everything is fine. Follicle output rate is little bit less, marginally less. This is the only difference. So I'm okay because I do not want to lose the patient whenever the patient come and patient is in mood to start IVF. I never refuse. I start the random start protocol. Now, what is my way of doing random start protocol? So consider a different scenario. One scenario is the lead follicle has acquired dominance or recruited. So that follicle is 10 millimeter. The another scenario, the follicle has grown up to 13, 14 millimeter. Third scenario, the follicle has grown up to say 16 millimeter. So the management of all these three scenarios is different. Suppose the single dominant follicle has grown to 10 millimeter only, and rest all follicle cohort is less than 9 millimeter. So in this scenario, it's very simple. Either you start gonadotropin antagonist together, option number 1. Option number 2, medroxyprogesterone with gonadotropin simultaneously. And option number 3, start with the gonadotropin, and when that lead follicle reaches 14 millimeter, then you start antagonist. So these are the three options when the lead follicle is 10 millimeter. Now another scenario when the lead follicle is say 12 to 13 millimeter. So this 12, 13, 14 millimeter is such a diameter. There are chances of quick LS surge. And the follicle LS is likely to happen. So I do not want, the paper have suggested to start like first scenario, like start gonadotropin and antagonist together, start gonadotropin and medroxyprogesterone together. But my way of stimulating this scenario is different little bit. So what I would do, I would start option number 1. I would start with the gonadotropin without any antagonist or medroxyprogesterone. So as I start gonadotropin, the follicle which was 13, 14 millimeter will grow 15, 17, 19, 21, 22, and rest other follicle also will grow. So once this lead follicle reaches 21 millimeter or 22 millimeter, that is going to happen in next 2 to 3 days only, or then there will be a LH surge. is going to happen, because once the follicle gets mature, then LH surge is going to happen when, especially in the presence of E2 more than 200. So LH surge is inevitable. So if LH surge has happened, that's a primary LH surge. That will cause the luteinization of that primary, the dominant follicle, and all other follicles will be still smaller than 12 millimeter by that time. So they have not acquired adequate LH receptor. So with this LH surge, they are not going to be affected. But this primary LH surge will prevent a secondary LH surge when all these rest of the follicles are going to grow. So this scenario will be like luteal stimulation. So in this scenario, I don't have to give antagonist or progesterone, anything. So that's the first way of doing. Second, which is a more safer way, to give agonist trigger. The same day you give agonist trigger and start progesterone. And from next day you start gonadotropin. So this agonist trigger will cause LH surge. And if the follicle at all acquires the LH receptor, that will cause luteinization, and that will make your cycle simple. And you already started progesterone. So this way you can continue with the cycle. Now coming to a third scenario where the follicle has reached up to 16 millimeter, then I would give trigger and convert this cycle into a luteal stimulation. So this is how I do random start stimulation. Hello?
Yeah, I hope that, yes, that answers the questions.
Yeah.
So basically, at the time when you do the scan for a random start, you have to look at the size of the follicle, which is the most important deciding factor. That what you are going to do in next couple of days or 3 days.
Yeah.
So thank you so much. I think we have taken all the questions, and it's 9:19. So thank
Yeah.
you, Issa. Thank you, Dr. Anu, and thank you, Dr. Sessi, for inviting me into this wonderful webinar. Thank you, Dr. Rajesh, Dr.
Thank you.
Sujata, for coming here. And I hand over to Dr. Anu.
Rajesh, my point to you suggest, Dr. Andhir
Yeah.
here. You told that if the failure is there, you suspect a embryology part. So we have always Monica fights with me. Why you're not giving result? Your class is not good. I fight with her because I have given a good class. So I think it's a joint responsibility. That's all.
Dr. Randir, I was waiting for you to respond. I was wondering why is
So
he
now
not.
what?
I was waiting. Why you
Even I was
not said anything?
No, Dr.
See.
Anu, I was listening a lot and all because there is always there. So seed and soil, I think seed and soil, they both play jointly and 50-50%. So, and if you'll go, Rajesh sir, we have got the embryo has got the many capacity, because we have seen the literature, even grade 2 or even 3 and 4 embryos they have implanted. So according to me, the endometrium part is more important for me, but you all people decide that. That's all, sir. Thank you, sir.
Thank you.
Thank
Thank
you.
you, Rajesh.
Thank you so much. Thank you for giving opportunity. It
Thank
was a
you, sir.
nice
Thank
experience. Thank you so much.
Thank you, sir.
Yeah.
So, Dr.
Yeah.
Fessi, would you like to conclude?
Dr. Fessi.
So from UNS, Mr. Manoj Joshi, he is there for the for vote of thanks.
So, am I audible?
Yeah.
Yeah, very much.
Yeah, good. So I know it's almost 9:27. So kindly allow me a couple of minutes. So in fact, I was also making a note to it was truly an enlightening session for all of us at UNS. So first of all, thanks a lot to all esteemed experts who have joined us this evening, including the audience for and trust us, this is 16th series of ISAR UNS Fertility Catalyst webinar. And I think we are extremely thankful to national body of ISAR for giving us this opportunity. And many young and upcoming doctors also are benefited with this. So all of your presence has and insightful contributions really made the session truly enriching for audience as well as all of us at UNS. We are delighted to share that today's event possibly has crossed 500 delegates because the faculty link is different and through different link the doctors have connected. So once again, I would like to extend my heartfelt gratitude on behalf of UNS to distinguished speakers, Dr. Sujata Kar for her valuable and very meaningful insights on novel methods of ovarian stimulation. Dr. Rajesh Karadia, in fact, possibly you would have had a few more questions to answer, but yes, paucity of time, we need to conclude. And for a very clear and informative session, Dr. Karodia, briefing on the role of progesterone and gonadotropin in ovarian stimulation and other roles. Sincere thanks to all the chairpersons and panelists for the very, very highly contributing and meaningful value add. Special thanks to ISAR National Body, Dr. Amit Patki sir, Asha Bakshi ma'am. Dr. Faisal Luis is always there to support. Dr. Nandita, Dr. Madhuri Patil and Anu Agrawal madam. So with this, we conclude this scientific feast program. And thank you so much once again to each one of you.
Thank you so much. Thank you all.
Thank you. Thank you,
Thank you.
everyone.
Thank you and
Thank
bye-bye.
you.
Thank you.
Bye. Good night.
Bye bye, ma'am. How are you? Take care. Good night.
Yes, thank you. Thank you, Dr. Monica. Thank you very much. Thank you,
Sir,
Dr.
can I end now?
Snehal. Just be hold on. Thank you, Dr. Snehal.
Hello, sir.
Yeah,
Yes, ma'am.
yeah, doctor.
Sir, I joined a little late, so I could
Right.
attend the second part. Where can I access the recording, sir?
So
Any
tomorrow
such?
we are going to receive recording that I will share
Okay.
with you. Yeah.
Sir, and I was not aware of the previous series of these webinars that are going. So all the webinars, any platform wherein these are shared, sir?
So we
Ma'am,
have
you are
That would
based
be a
somewhere in
useful
South.
resource for
On
all the.
YouTube, you can find all the series, the videos and recordings. Yeah.
Which site, ma'am? YouTube
So
link
there
or
is a
something?
YouTube channel is this RX event ka YouTube channel wherein you will find
RX,
all the
sir?
RX
Can
event.
RX
RX
event.
RX event.
Or ma'am, you can directly even search like ISAR Fertility Catalyst webinar series. You can find those videos.
So ma'am,
You can directly search
Yes.
it.
I'm requesting to you,
Yes,
can I
sir.
get your mail ID so that
Yeah.
I can share
Yeah.
all the
Yes,
recordings.
sir. Yes, sir. Yes, sir. That would be
So
really
you can
helpful,
take
sir.
slow here.
Yeah.
Can chat.
So,
Ma'am, if somewhere you are based in South, ma'am, Reddy ma'am.
yes, sir. Yes, sir. I'm from Hyderabad.
Great.
Okay.
So I
Which
was not
hospital
aware of
it is?
this
Which
webinar
hospital you are
series.
associated
So I
with?
have shared the mail ID, sir.
Yeah.
If kindly the link for the recordings can be shared on that mail ID, that would be really helpful for me.
Sure.
Kindly share your
So we
contact number
couldn't
as well.
get your
Our colleague
mail
will
ID.
reach out.
Yes, sir.
Where you shared, ma'am?
In the general chat, sir.
No. I can't find your mail ID.
The last one, sir. Last message is mine.
Your last message is the initial part of webinar. Request to kindly share
No,
the
sir.
recording.
After that, okay. Maybe I'm sending not in the, yeah, I was messaging Mr. Manoj Joshi. Yeah,
Yeah,
I'm
he's there.
sending the
Yeah.
normal one also, sir.
Great.
Right, perfect.
You have messaged to the right person, ma'am, actually.
Okay, sir. Thank you.
He's based at
Thank you.
Hyderabad and he is the leader for South Zone.
Yes, sir. So I have shared my mail ID as well as the mobile number, sir. So if that can be done, it would be really grateful.
Great.
Sure.
Just wait, ma'am.
Yeah.
Actually, still we cannot find your mail ID and
Manoj
I'll
Bhai,
share. I'll share.
Check.
Nakul.
No.
Okay, you
What
got
ma'am
na Manoj,
says?
sir?
Yeah.
What I will do, I'm taking a pic and then sharing with you.
Sure.
Right. Perfect. Okay,
No
thank you very much.
Sure, sir. Thank you, sir.
Thank you, doctor. Thank you, Dr. Reddy.
Thank you. Thank you.
Nakul sir, can I end now?
Yes, thank you, Sanskruti. Thank you again, sir. Manoj sir, really thanks.
you,
Bhakti, thank you very much. Thanks for your contribution.
Thank you,
भैया ऐसा है मैं फील्ड में था भाग दौड़ के आया बोले थैंक्स नोट देना है
Understood.
Stress मत लो.
Thank you, friends. Thanks for your contribution, sir. Thank you very
भाई ने
much.
समा बांध दिया था गुड सी मेडिकल टीम ऑलवेज वी आर एक्सट्रीमली थैंकफुल टू यू
Yes.
Nice teamwork, Shruti, by you, Sanskruti and Bhakti. So
So both are the
all the
rising
believers.
stars, sir. Manoj sir, Sanskruti and Bhakti, they are the rising star. मतलब
Yeah.
एक,
तो रहता है ना समटाइम एक वर्ड है यानी कम बोलते हैं बट काम तगड़ा है ऐसा है आवाज कम आती है इनकी बट काम वो एकदम परफेक्ट वाला है
yes.
अब इसको कैसे इसको क्या वो मेरे को ये वर्ड याद नहीं आ रहा है वो देखता हूँ चैट जीपीटी पे डालता हूँ
Right, sir.
Also what?
ग्रेट बट इट वाज अ ग्रेट शो ठीक है
Right.
यस
Thank
मैम
you.
थैंक
Thank
यू
you.
Thank you.
ठीक
So I
है
have shared my mail ID and the number in the general
या
chat
गॉट
as
इट
well,
मैम
sir.
गॉट इट
So I
Go-
definitely
Got
look
it,
forward to
ma'am.
that.
Yeah.
Thank you, sir.
टीम विल
Thank you.
रीच आउट टू यू
I got
टीम
it, doctor. I will
विल
WhatsApp you as well.
Thank you, sir. Thank you.
चलो नकुल भाई थैंक यू सो मच फॉर अपॉर्चुनिटी
Thank you,
टेक
sir.
केयर
Thank you
गुड
very much.
नाइट बाय बाय मनोज भाई थैंक यू सो मच फॉर योर
Thank you,
presence
Yogi bhai.
बाय बाय टेक केयर गुड नाइट
Or Nakul, thank you.
Bye, sir. Bye, sir. Good night. Good night.
Bye.
Bye.
Bye. Good night, all of you. Thank you.
Okay, sir, I'm ending now.
यस यस यस